Clinical chemistry, cardiac disease, and markers. Heart disease is typically categorized as infective, congenital, or hypertension. Infective would be caused by infection, so rheumatic heart disease, infectious endocarditis, pericarditis, typically treated with antibiotics. Congenital would be physiological defects at birth that are corrected by surgery, or hypertensive. Hypertension is high blood pressure. It's corrected by diet, exercise, and medication. Congenital heart diseases, etiology often unknown. Environmental and genetic factors play a role. Factors associated with congenital defects include maternal rubella infection, maternal alcohol abuse, drug treatment, radiation, genetic or chromosomal abnormalities. True heart diseases that someone's not born with, that they can kind of develop over the course of their lifetime. Congestive heart failure, or CHF. It's characterized by edema in the lungs and the rest of the body. It's caused by coronary artery disease, cardiomyopathies, myocarditis, valvular disease, and cardiac arrhythmias. In congestive heart failure, the heart starts to be able to beat a little bit faster, so it loses a little bit of its function, which causes a decrease in heart rhythm. That's going to cause excess fluid leaking out of the bloodstream, and that excess fluid can accumulate around the heart, causing the heart to slow even more. And it's kind of a positive feedback mechanism that's going to continue and continue and continue until the heart just doesn't beat anymore. Coronary heart disease, or CHD, is ischemia. Ischemia is a constriction in blood flow, typically in the coronary arteries, so the blood vessels that serve nutrients to the heart muscle tissue itself. So they're on the surface of the heart, and they're going to provide nutrients to the heart muscle tissue. It leads to angina pectoris, or myocardial infarct, or heart attack, eventually congestive heart failure. Angina pectoris is chest pain. Myocardial infarct is the death of myocardial tissue. So that's when we have blockage of one of those coronary arteries, and anything distal to the blockage would be suffocated and dies. Symptoms of heart disease common include dyspnea, or difficulty breathing, syncope or fainting, cyanosis or bluing of the skin, typically around the lips, pain, angina pectoris, palpitations, fatigue, edema, or swelling. Unusual symptoms include cough, abdominal pain, but abdominal pain is a little bit more common in women than it would be in men. Hemoptysis, headache, sweating, vision or speech disturbance, weakness of extremities, weight loss, nausea, vomiting, and fever. Hypertension, or high blood pressure, is when systolic pressure is greater than 160 and diastolic is greater than 95. Incidence increases with age, so it's 4% at ages 20 to 29, 50% at middle age, 65% over age 80. It's more common in Black population, and it affects all organs, especially the kidney, brain, and heart. Hypertensive heart disease is caused by increased peripheral resistance, increases workload of left ventricle, resulting in hypertrophy and dilation. Hypertrophy is an increase in growth of that side of the heart. So if you've ever heard of an enlarged heart, that's what they're talking about. And dilation, so increase in the size and the width inside of the heart itself. Causes mitral valve to allow regurgitation of blood into the left atrium, which results in dilation, increased pressure in the left atrium. Increased pressure is transferred to the right side of the heart. It's associated with increased prevalence of atherosclerosis. Primary versus secondary hypertension. So primary hypertension, 90 to 95% of patients have its no known cause. So multifactorial, genetics, race, gender, environmental, also cardiac output factors or peripheral vascular factors. Secondary hypertension with identified source of the problem. So renal disease can cause sodium retention, which can cause hypertension. Malignant hypertension, when you have severe renal disease, it causes renal cell inflammation and destruction. Primary aldosteronism is due to abnormal control of electrolyte excretion, and pheochromocytoma due to an increased excretion of catecholamines from a Schaufman tumor. So there are primary reasons where there's just something wrong with controlling the blood pressure directly, and secondary means that something else and another organ system is affected in the body, and that's causing hypertension to arise. Congestive heart failure affects 1 in 100 people in the United States. It results from the inability of the heart to pump blood effectively. It leads to lower cardiac output. The left side fails, and excess fluid accumulates in the lungs. Pulmonary edema, reduced output to systemic circulation. The kidneys respond with excessive fluid retention, making the heart failure worse. The right side fails. You have excessive fluid accumulates in the systemic venous circulation. You have generalized edema, diminished blood flow to the lungs, the left side of the heart, decreased cardiac output to the systemic artery or arterial circulation. Laboratory diagnosis of congestive heart failure. We're going to look at blood urea nitrogen, or the BUN. It's the measurement of the serum urea nitrogen. There's enzymatic methods and direct methods. An increased BUN is associated with renal failure. The BUN-creatinine ratio provides a rough indication of causes of renal failure. Congestive heart failure, you have an elevated BUN with normal creatinine, and there's a high ratio that's indicated. Pre-renal uremia is indicative of reduced renal blood flow. Uremia is an increase in blood urea. Azotemia is an increase in nitrogen-containing end products, including urea, creatinine, and uric acid. Brain natriuretic peptide, or BNP, is released in response to ventricle volume expansion and pressure overload. It works in tandem with atrial natriuretic peptide, and it's approved for the diagnosis of CHF. Less than 100 CHF is unlikely, 100 to 400 CHF is likely, and greater than 400 CHF is very likely. It provides prognostic information. Coronary heart disease is caused by lack of nutrients and oxygen supplied to the heart muscle. It results in myocardial ischemia. You have a decreased blood supply to one area of the heart due to atherosclerosis, thrombosis, spasms, and embolisms. It can also be due to anemia, carbon monoxide or CO, hemoglobinemia, or hypertension. Coronary heart disease risk factors. So age, it's a common finding after age 40. Gender, males are more common than premenopausal women. After menopause, women are affected similarly. Family history. Smoking, there is a direct relationship between the number of cigarettes smoked and congestive or coronary heart disease in men. It's related to decreased HDL, increased LDL, increased platelet adhesion, vasoconstriction, increased fibrinogen, and clot formation. It's not well characterized in women or those who smoke pipes or cigars. Hypertension, so both systolic and diastolic hypertension for both men and women. Sedentary lifestyle, response to stress, diabetes mellitus, and hyperlipidemia. D-dimer is something that can be tested for, and it's elevated with clots, so it's associated with pulmonary embolism and certain strokes. It's produced during clot degradation. There are two identical domains: primary and secondary fibrinolysis, tissue plasminogen activator, and as a result of thrombic disease. It's detected by monoclonal antibody, which can lead to false negatives and false positives, but D-dimer levels are elevated when there's a clot. Consequences of ischemia. So congestive heart failure, angina pectoris, this is the symptom of inadequate perfusion. We have chest pain without tissue damage. Unstable angina is most severe. It's present at rest and progresses rapidly to a myocardial infarction. It's difficult to differentiate from a myocardial infarction. There are no enzyme elevations or characteristic ECG changes. And then we have myocardial infarction. So you can look at this picture here. So coronary atherosclerosis, you have plaques that are starting to build up inside of the arteries. The plaques cause ischemia, or a restriction in blood flow to the area. That can lead to chest pain, arrhythmia, and eventually congestive heart failure and death. Plaques can also cause coronary thrombosis, which can lead to a myocardial infarct. You can have cardiac arrest, arrhythmia, ventricular aneurysm, scarring, myocardial rupture, or heart failure, all leading to death. So myocardial infarction is defined by history of chest pain, abnormal electrocardiogram, and biochemical markers. It occurs when blood flow to the heart is suddenly blocked, leading to ischemia and death of myocardial tissue. Area of blockage becomes inflamed and necrotic, followed by the release of cellular enzymes. The damage is irreversible. Necrotic tissue will eventually be replaced by fibrous scar tissue. So when we block blood flow to heart muscle tissue, so the heart is a muscle, it needs to be able to exchange wastes and nutrients. If we cut off the nutrient supply, the heart muscle tissue will die. And once dead, it's not going to regenerate or grow back. It gets replaced by fibrous scar tissue. Fibrous scar tissue is not conductive, so that means it's not going to generate electricity, so it's not going to contract. So now we have scar tissue on the surface of the heart, which is basically going to cause the heart to forever not function properly. So from the time that a heart attack happens until the time that the person dies, their heart will never function like it did before the heart attack. That scar tissue can't be replaced by normal muscle tissue. It will forever be dead weight that the heart now has to move along with its normal function. Small heart attacks someone can live with, and they don't have an overall significant impact on the person's health or well-being. But if we have larger heart attacks, that scar tissue, it can kind of be a weak point, so that the heart may rupture, or that ventricles may burst in the area where they have that scar tissue, and that can happen a couple months after the person has recovered from the heart attack. Suddenly, their heart wall can become very weak, and they can end up dying. Secondary heart attacks can occur because those risk factors are already there. There's an increased likelihood that more heart attacks will happen later on. So all around, very terrible situation when you have a heart attack. The extent of the damage is related to the size and location of the infarct. So if it's blocked very high up, that means that a large blockage has occurred and much of the heart muscle tissue is no longer getting nutrients, and that can cause death of the person instantly. If the clot is farther down in the coronary arteries, then that would mean that just a small amount of the heart muscle tissue was deprived of nutrients. So a small part would die, and typically people can live after that type of heart attack. So diagnosis of the myocardial infarction depends on EKG changes, patient history, and serum markers. 2 out of the 3 of those is necessary in order for the WHO to kind of agree that there was a myocardial infarction. So the use of cardiac markers, it's most useful when individuals do not have characteristic ECG changes. The definition of MI is based on characteristic enzymatic and non-enzymatic elevations. Characteristics of an ideal marker would be abundance in cardiac cells exclusive to myocytes. So this is where we have some issues, because a lot of the markers that we use aren't specific to heart muscle tissue or cardiac cells. Rapid release after myocardial injury. This can also sometimes be an issue because if a person has prolonged chest pain for several days, they may have suffered a heart attack. But if we only have a marker that was released immediately after the heart attack occurred, then we would have difficulty sensing those levels days beyond when the heart attack occurred. Persistent in plasma, but not so long as to mask a recurrent infarction. Ease of measurement and rapid test methodology. So the size, low molecular weight proteins increase or are released faster. They peak earlier than high molecular weight proteins. The cellular location, cytoplasmic proteins are released sooner than structural proteins. The release ratio, some macromolecules may undergo local degradation after release. Clearance, smaller proteins are removed from the bloodstream more quickly. And specificity for the heart. So here are some markers that are commonly used to assess myocardial injury, and you can see whether they're specific to the heart and what their diagnostic window is. So aspartate aminotransferase has a low tissue specificity, and it has an intermediate window. So from the time that the myocardial infarction happened, an intermediate amount of time would pass and levels would still be elevated. Creatine kinase has a medium specificity and an intermediate diagnostic window. CKMB has high tissue specificity, but it has earlier diagnostic window, so that would have to be measured earlier on in the heart attack. Lactate dehydrogenase has a low specificity and it can be measured late. Lactate dehydrogenase 1 has a high specificity and it can be measured late. Myoglobin has a medium specificity and that has to be measured early. So within the first 8 hours, you want to try to get 2 separate measurements within the first 8 hours of the symptom onset. And cardiac troponin I, absolute tissue specificity, and it has an intermediate diagnostic window. So here you can see the diagnostic window. So if we're at 50 hours, kind of everything starts to drop off at that time, but you can see CK when that peaks, LD kind of peaks a little bit later, AST peaks earlier, and CKMB peaks earlier as well. Aspartate aminotransferase has a little bit higher specificity for the heart, but you can see all of the other areas where we might see elevated levels. Liver is another one that this one is used for. LDH and CKMB, so CKMB peaks here. LDH can remain elevated for a longer period of time. LD1 and LD2, they're cardiac isoenzymes. Specifically reactive to 2-oxybutyrate, substitute for pyruvate or reverse reaction. Reduction only occurs in the presence of significant elevations of LD1 and LD2. Elevated levels indicate increased levels of cardiac isoenzymes. So if we look at this case study here, we have a 68-year-old man, sudden onset of chest pain, left arm pain, dyspnea, so shortness of breath, weakness while away from home on a business trip, 2-pack-a-day smoker, greater than 20 years of smoking history. So we measure some cardiac markers. At 7:30 a.m. versus 4 o'clock p.m., so we have 2 different measures. CKMB levels increased. You can see what's normal. They started out above normal and increased to way above normal. Myoglobin, same thing, increased. And troponin T, which isn't as specific for cardiac muscle, but it's still used as a marker. We can see it's less than 0.1 and then it's 1.3 later on. So if we look at the triangle here, we haven't gotten EKG information yet, but based on the patient history and serum markers, so their history, smoker, and serum markers are increasing, we can diagnose MI, or myocardial infarction. Creatine kinase or CK isoenzymes. So if you recall from previous lectures, CK1 or CKBB is predominantly in the brain. CK2 or CKMB is relatively specific to the heart. CK3, CKMM is cardiac and skeletal muscle. So if we look at total CK, you can see this here, and CKMB, they kind of peak here. So peaks at about 24 hours, returns to normal between 48 and 72 hours. CK2 levels need to be measured serially, so 0 to 3, 3 to 6, 6 to 9, and 12 to 24 hours after presentation. Determination of CK2 is electrophoretically or enzymatically. You want to measure the total after removal of the M subunit, after the removal of the B subunit, and then calculate. And there's the calculation. There are immunoassays that have antibodies specific for CK2, and limit of detection is 1 microgram per liter. It detects an increase in CK2 earlier than standard assays, and it's 100% specific for CK2. Factors that affect CK2 levels: the size of the infarct, CK2 composition in the myocardium, and concomitant concomitant skeletal muscle injury. Large amounts of total CK from muscle injury may mask the absolute amount of CK2. Then we have reperfusion reactions. So monitoring CK2 assists in monitoring reperfusion therapy. So tissue plasminogen activator. Successful therapy is associated with a rapid increase in markers and an early peak. Successful monitoring necessitates frequent sampling and rapid analysis of markers. Myoglobin, which we discussed earlier in the course, this is a heme-containing oxygen-binding protein. It's found in cardiac and skeletal muscle, and its function is to store oxygen in the tissues. It's rapidly released upon muscle damage. Skeletal or cardiac muscle damage can lead to an increase. If it's cardiac muscle damage and we want to use this as an evaluation of myocardial infarction, this has to be measured early on, so within the first 8 hours is ideal. So here you can see when myoglobin would increase. So myoglobin can be measured early, and then levels start to decline later on. CKMB is going to be measured a little bit, can be measured a little bit later, and levels are going to remain elevated for a period of time. Myoglobin is most often detected by immunoassay, ELISA, fluorescent, turbidimetric or nephelometric detection, latex agglutination. Analysis considerations, so antibodies must be specific for myoglobin so that there's no cross-reactivity with hemoglobin. It cannot distinguish the source of the myoglobin, so cardiac versus skeletal. Non-hemolyzed, non-lipemic serum. Do not use SST tubes. Can also use heparinized plasma. EDTA interferes with the assay. The effects of anticoagulants can be assay specific. It's stable at 4 degrees Celsius for 1 week, 4 weeks at -20. Urine samples can also be analyzed. Collect without preservative and analyze within 24 hours. You want to store at 2 to 8 degrees Celsius and do not freeze. Troponin. So if you remember back to anatomy and physiology, and we talk about muscle structure and how a muscle contracts, we have these troponin, tropomyosin, and they are going to form a complex to help with muscle contraction. So troponin C is the calcium binding subunit. Troponin I is the inhibitory subunit, which inhibits ATPase, and troponin T interacts with tropomyosin. It's localized primarily to the myofibrils, and a small amount is found in the cytoplasm. Cardiac-specific troponin isoforms. So troponin T is cardiac-specific. There are cardiac-specific and skeletal muscle-specific isoforms. It's encoded by separate genes. Small amounts are found in skeletal muscle during development, in regenerating muscle, and in diseased muscle. Muscular dystrophy, polymyositis, and chronic renal disease, or polymyositis, and chronic renal disease. Troponin I, or TNI, or CTNI, cardiac-specific and skeletal muscle-specific isoforms. They are encoded by separate genes. CTNI is not observed in normal, diseased, or regenerating skeletal muscle. CT&T is insufficient for effective early diagnosis, so 50 to 60% sensitivity for up to 6 hours post-myocardial infarction, similar to CK2. Sensitivity is greater than CK2 at later time points. It detects those patients with unstable angina or mild cardiac injury. It indicates an increased risk for myocardial infarction. Differentiates individuals with increased CK2 due to skeletal injury from those with concomitant MI. Excellent marker for myocardial injury in the presence of other conditions: sepsis, drug-induced toxicities, chronic disease, malignancy, hematologic disorders, and non-cardiac surgery. Troponin I is similar to CK2 for the detection of myocardial infarction, similar kinetics to CK2, and it stays elevated longer. It's insufficient for very early diagnosis of MI. Specific for myocardium, it remains undetectable in cases of skeletal muscle injury with no cardiac involvement. It's not elevated with excessive exercise, with Duchenne's muscular dystrophy, chronic renal failure with dialysis. It's useful for the diagnosis of perioperative MI in non-cardiac surgery. Detection, chemiluminescent immunoassay, and fluorescent immunoassay, troponin 1. The reaction is quantified by fluorescence, and you can read a little bit more about the details here. So this is a table because it shows many of the cardiac biomarkers and when they would peak and how long they stay elevated. So if we look here, myoglobin has the shortest half-life, and then it's going to completely disappear. So that one has to be measured early. CKMB, troponin I, and T are all going to kind of decrease after about a day. CKMB goes away completely after 2 days, while troponin I and T will stay elevated for several days after a myocardial infarction. Total CK will be here, and LDH has a mild increase for several days. So kind of the purpose of looking at this is to realize that multiple markers are necessary. If a patient has had heart issues or has felt chest pain for several days, myoglobin is not going to be something that you're going to measure. You're going to measure the troponins to determine if there are any elevations in those. And if there aren't, then it's probably not a heart attack. But if it's been pretty quick, then you're going to get multiple blood samples right away to try to evaluate if there are changes between those 3-hour time intervals. You can see the characteristic and advantages in this table for troponin I and T. New recommendations for myocardial infarction diagnosis. Detection of myoglobin early, so within 9 hours of presentation, and then detection of either troponin I or T at presentation, and then every 3 hours after presentation. There's a lot of other causes of increased troponin T. You can read those here. So using one marker alone is not going to be enough for diagnosis. Risk stratification, so using cardiac markers to identify patients with unstable angina at increased risk for myocardial infarction. Up to 30% are going to progress to myocardial infarction or cardiac death within 1 year of initial presentation of troponin I, T, or CK2. 25 to 33% of unstable angina patients have increased troponin I, T, or both. 20 to 35% present with increased levels within 24 hours of symptoms and progress to myocardial infarction or cardiac death within 1 month. Measure at presentation and then 12 hours later. So this is a table that just shows sources of cardiac injury. So we have ischemia. Ischemia is a constriction in blood flow that can lead to myocardial infarction, which can lead to cardiomyopathies and cardiac injury, or directly to cardiac injury. Dilated, hypertrophic, or stress-related injuries can lead to cardiomyopathies and cardiac injury. A pulmonary embolism can cause increase in wall stress, which leads to cardiac injury. Wall stress in general can lead to cardiac injury, and you can kind of go across the list here and look at other sources of cardiac injury.